ALF, and hyperammonemia should be an independent indication for CRRT in this context. A second extracorporeal modality is plasma exchange. And this is actually high-volume plasma exchange. This is a study published almost 6 years ago that showed the first trial that showed a transplant-free survival benefit of a therapy in acute liver failure. This is a lot of FFP. You needed a really supportive blood bank. This is 8 to 12 liters of FFP compared to what we use as 4 to 5 in TTP-HUS. And so this has now become an important add-on to high-dose CRRT, and I'll share with you a slide that goes over this. Last sort of bullet point before we get into the case is coagulopathy. I'm just going to, for the sake of time, just highlight the big-ticket items on this slide. I've already mentioned that INR is your best measure of synthetic function. The second bullet point here is an elevated INR does not necessarily translate to a higher risk of bleeding. These folks can actually form DVTs with INRs 11. So resist the urge to correct the INR with FFP or NOVA7 or PCC unless there's signs of active bleeding. All right, let me just finish up with this case. This is actually a case from 4 years ago, 30-year-old, Korean Airlines flight attendant sort of coming through just a sort of a stopover in Atlanta, was found down in her hotel room. We think maybe a weight loss supplement that caused acute liver failure. She actually presented a grade E. Neurologically, grade 4, encephalopathy, ammonia of 500, so she's intubated. Cardiovascular-wise, severe shock on maximal dose of, I think when I got the call, there were almost 4 pressors on board. INR 7, pH of 6.9. And so we just, as a Hail Mary, got her over to EUH. We started the settings I told you about to target the metabolic acidosis and to target the hyperammonemia. We co-initiated PLEX through a second catheter with a goal to see if we can make a dent in the blood pressure. Within 24 hours, ammonia down to 150. Pupillometry's readings were stable. Head CT was stable for what it's worth. We corrected the metabolic acidosis. There was a dramatic improvement in shock down to single low-dose norepi. We actually transplanted her. And she's 2 years out from transplant back in Seoul. So I think this case, and for those of you interested, I've put the reference on top. It's published in a liver journal. But this highlights the efficacy of high-dose CRRT and the co-administration of PLEX in a very sick patient as a bridge to transplantation. All right, so just to summarize some thoughts, think about encephalopathy and coagulopathy, and that's sort of the triggers for referral. Early intubation for grade 3/4 HE. Aggressive management of hyperammonemia, because that's your mediator of ICP elevations. Avoid treating an elevated INR if there's no signs of active bleeding, and use it as a prognostic indicator. If you need to start dialysis, please make sure CRRT is your default mode irrespective of the hemodynamic status. And then finally, evolving role of plasma exchange in acute liver failure. Do we have time for questions? Yes. Okay. So first question, you got a 22-year-old lady presents with acute liver failure to Tylenol, stable vital signs, grade 2 encephalopathy, INR 7, no signs of active bleeding, serum hemoglobin is 13. What is the appropriate next step in the management of a coagulopathy? You got, great. All right, that's 100%. Great. All right. Correct answer. Yeah. Second case, 35-year-old, Wilson's disease, grade 3 encephalopathy, intubated. So what would be a choice of hepatic encephalopathy management? Those are your choices. Great. So just to recap on this is very different from what you would do for a cirrhotic, grade 4. Right, you're not worried about ICP elevations. There you think about lactulose, rifaximin, zinc. And just as a sidebar note, some of you may know we do albumin dialysis. It's called the MARS system. That is specifically used for refractory HE in cirrhotics. We have stopped using it in acute liver failure because our CRRT experience has been so good. But MARS works really well in reversal of HE in cirrhotics. Separate conversation. But thank you for your attention. Yep.
Our next speaker is Dr. Benjamin Damas. He is one of our cardiology and critical care attendings. He'll be speaking to us about heart failure management in the ICU.
All right. Thank you, everyone, for being here, allowing me the chance to talk. So I'll be talking about cardiogenic shock and a team approach to treatment of cardiogenic shock. I have no disclosures. So the objective today, so we're going to learn about the structure of cardiogenic shock teams. We're going to understand the importance of early recognition of cardiogenic shock, and we're going to talk about the data that supports the formation of a shock team. So I'm going to start off by talking about a case that was inspiration for this talk, along with a paper that was published last year. But we had a 70-year-old male who was admitted to one of our partner hospitals who presented with chest pain and shortness of breath. He had a history of hypertension, diabetes, and dyslipidemia. His vitals on presentation, he had heart rates in the 110s, his systolic blood pressure was 90s over 100, respiratory rate in the 20s. His EKG was fairly unremarkable. On his labs, his creatinine was a little bit elevated, normal lactate, troponins were a little up. His echo done at the bedside, he had an EF of 25%, globally down, moderate RV dysfunction. They took him to cath that day, and he had multivessel disease with no culprit lesion, and he had an elevated LV-EDP of 25. So he was then admitted to their ICU, and the cardiology team called our transfer center to initiate transfer for higher level of care. So I'm going to leave that here, and we'll come back to this at the end of the talk. So defining cardiogenic shock, so we think about this in terms of layers. So stage A is patients who are at high risk for shock. So these are people who present with acute MI and decompensated chronic heart failure. On top of that is going to be stage B, which is patients who are starting to show evidence of failure. So they typically have early signs of hypotension, tachycardia, but there's no hyperperfusion. Progression from there is going to be stage C. So now you have tachycardia, hypotension, and hypoperfusion. And this is where you think about initiation of treatments, whether that being pharmacologic or MCS. From there, you start to deteriorate, and you now move into stage D. So this is your deteriorating shock patient who is being treated but is not improving. And those who continue on into stage E are as refractory shock, accompanied by collapse of their entire circulatory system. So when you see systolic less than 90, MAPS less than 60s, heart rate greater than 100, a cardiac index of less than 2.2, wedge greater than 15, lactate greater than 2, and evidence of end organ dysfunction, you need to think about shock and you need to think about which stage they are currently in. We typically see a pathway of shock. So they'll start off at A or B, and as time goes on, they'll move in a linear fashion from C to D to E. If you initiate treatments at stage C, best case scenario is that they stay there and they'll move back to B and then ultimately A. However, those that move on to D and E can move quite rapidly, so you have to be aware of that. If treatment starts to take effect and you start to see improvement, you generally move slowly back down the pathway, but don't be surprised for those who deteriorate if it's a rapid progression from C to D to E. So in the mid-2010s, around 2014, 2015, several hospital systems decided to come up with a shock team pathway. And this has been more or less what several centers across the country have adopted. So the pathway generally looks something like this, where you start off with a patient who has suspected cardiogenic shock. There is some sort of an activation system which forms a formation of the shock team, alerts the shock team, which is generally consisting of your critical care cardiology, advanced heart failure team, interventional cardiology, cardiac surgery, and your ECMO team. This team gets together to evaluate the patient, review the available data, decide if there's any additional data points that they need, come up with an assessment and plan for the patient, and then enact that plan. So this is typically what you see for any system that's developed their shock team. So based off our Sentinel event, we're in the process of forming our own shock team, and this is what we've come up with, this sort of layered idea. So our initial call is going to go out to our heart failure team, our critical care team in the CCU, and then our ECMO attending on call. They'll review the data, decide where the patient is on that shock pathway, and decide if they need to pull in any other experts of our system. cardiac surgery, vascular, interventional, palliative care. After your initial treatment strategy and review that strategy, you'll then bring in your next layer, which is your ancillary staff to support that patient. So we think about physical therapy, spiritual, nutrition, and social workers. So we start narrow and broaden out according to the patient's needs. So a cornerstone of cardiogenic shock therapy and the shock team management is going to be data. And this comes in the form of invasive hemodynamics with a PA catheter. So your PA catheter is going to give you your right atrial pressure, your PA systolic over diastolic, and your mean. You can calculate your cardiac output and your index, your cardiac power output, and your pulmonary artery pulsatility index, all of which will help you drive decision making. Historically, PA catheter utilization has been a bit controversial, and it has not shown to be beneficial in broad populations of critically ill patients. In 2005, there was the ESCAPE trial, which showed no benefit in management of just decompensating heart failure. However, they excluded cardiogenic shock from that trial. In 2013, our heart failure guidelines recommended use of PA catheters for patients who are in respiratory distress or evidence of impaired perfusion, in whom the adequacy of excess of intracardiac filling pressures cannot be determined from clinical assessment. So basically, what does this mean? So this means that if you have diagnostic uncertainty, you put in a PA catheter to help define the shock, or if you're going to use your filling pressures, your cardiac output, your CPO, your PAPI to define your therapy. Those are going to be the indications, so diagnostic uncertainty or to help drive management. There was a study of 1,400 patients that looked at PA catheter utilization amongst cardiogenic shock patients, and this did not involve a team approach. And they found that patients who had full hemodynamic assessments, including all of your filling pressures and all of your output index, CPO, and PAPI, did quite well in terms of demonstrating mortality benefit. If you left off at least one of those numbers, your mortality benefit was less, and if you didn't have a PA catheter at all, you were at quite a bit of detriment. So there is some benefit in this sub-select population, cardiogenic shock, especially as we think about patients in the D&E realm, but it's imperative to use all of your numbers available. Missing numbers generally leads to poor outcomes. So what do we do with our numbers? What do we do with our hemodynamics and our filling pressures? We think about our MCS device table. So how do we decide which device is appropriate for the patient? We think about whether the patient is predominantly LV dysfunction and RV dysfunction. We think about whether the patient has elevated filling pressures. We think about whether they have a high SVR state or low SVR state. So if you're predominantly LV dysfunction, you're going to think about balloon pumps and Impellas. If you're predominantly RV failure, you're going to think about an RP Impella. And if you have bi-V failure, you're going to think about VA ECMO. Your balloon pumps and Impellas will help with high SVR states, and ECMO is going to help with your low SVR states. So you're going to put in your PA catheter, get all of your hemodynamics and your filling pressures, decide is it LV failure, RV failure, or bi-V failure, determine your SVR, and this will help guide what MCS device is most appropriate for that patient. So I'm going to review 3 shock teams that have published their data. The first one is the Utah team, and they published in 2015. So they looked at a cohort of 120 patients, pre-shock team and post-shock team, and they were able to demonstrate an improvement in 30-day all-cause mortality and in-hospital survival. They showed that their team demonstrated an improvement of 61% compared to 48% prior to their team. And this was mostly driven by the fact that they used less balloon pumps and they used more Impellas and VA ECMO. And this is indicative of what we just talked about, which were the patients had PA catheters in place, they had their filling pressures, they had their hemodynamics, and they were able to tailor the specific device to each patient. Pre-shock team, with a fewer amount of PA catheters used, they were using sort of a more standard approach, which was basically a balloon pump for everyone, and this was likely inadequate for a handful of patients. They also saw that with the shock team, they had earlier implant of MCS devices prior to transfer. So this leads us to believe that they had a conversation, they talked about how sick the patient was, the recommendation was to put in a device prior to transfer, so they arrived with a device in place. So earlier implant of MCS device allowed for greater survival along with more tailored approach to that particular patient. Ottawa published their data in 2016. Similar concept, they looked at pre and post shock team, and the shock team cohort, there were 60 patients, and the controls, there were 36. They did not see any difference in terms of survival to discharge, 30-day survival, or length of stay in ICU or hospital stay. It's not exactly clear why. It might be the fact that this is just a small population of patients, or it could be the fact that their protocol wasn't optimized for device selection. They didn't actually publish their protocol for review. They did use more MCS, and it was more tailored towards advanced MCS, Impellas and VA ECMOs, less balloon pump, but it's not exactly clear why their survival was not any better. However, they did show a longer-term survival. So at median 240 days post-discharge, they had a significant survival in the treatment group compared to the control group. And this was largely due to the fact that patients who were seen by the shock team had 75% follow-up in the heart failure clinic compared to 50% for those who wasn't. So there's a 25% improvement in survival along with a 25% improvement in heart failure follow-up. And this is likely due to the fact that the patients in a heart failure clinic were started on GDMT, optimized, which we all know has mortality benefits. So this team here highlights sort of the benefits of a multidisciplinary effect in the longitudinal care that they can receive post-discharge. Next up is the INOVA shock team. So they published their data in 2017. And so they looked at their outcomes in 2016, their 30-day survival at 2016, and then compared that to 2017 and then 2018. So they broke it down into acute MI cardiogenic shock and then sort of chronic decompensated heart failure that evolves into shock. So initially, they didn't see much of an improvement in the chronic heart failure that evolved to shock. However, they did see quite a bit improvement in acute MI. And then in 2018, they saw dramatic improvement in both. So this is likely a result to, again, a sort of a more tailored approach to MCS for each individual patient. They moved away from balloon pump for everyone to Impellas and ECMOs. Acute MIs saw dramatic improvement, likely due to the fact that more Impellas were used, which allowed for higher levels of unloading as compared to balloon pumps. And I suspect the same thing was for the 2018, probably with the introduction of higher, more powerful Impella devices. So as time went on, they were able to implement a team that provided higher levels of support, which allowed for them to sort of show dramatic improvements over a 2-year time span. They came up with a 30-day mortality risk after multivariate analysis. And so they just showed that with 5 or more risk factors, you had an 80% chance of dying. So the key takeaway from this mortality risk score is those which are modifiable and those which are not. So lactate of greater than 3 after 24 hours gave you 2 points. Pressors after 36 hours gave you 2 points. And a CPO less than 0.6 gave you 2, and a PAPI less than 1 gave you 1. So all 4 of those are potentially modifiable, mostly through the implementation of an MCS device. And again, as we sort of talked about, making sure that you're getting the right amount of support will allow you to dramatically affect those numbers and improve the mortality of the patient. Dialysis, dependence, diabetes, age greater than 71 are not necessarily modifiable, but things to be aware and make note of as you're sort of thinking about these patients. So when you got someone who arrives, they're in shock, you're trying to decide what to do, keeping these numbers in mind will allow you to assess the severity of the shock and which direction is the patient heading and what's modifiable and what isn't, and sort of help you direct the best course of action for that patient. So in 2021, the review of 1,200 cardiogenic shock patients, 10 of the 24 centers had shock teams, 14 did not. And so they reviewed all the data and assessed the outcomes. So they saw that 1/3 of the patients had acute MI shock. 2/3 were the chronic decompensated heart failure patients who evolved to shock. They all presented with a lactate greater than 2. They had a pulmonary capillary wedge pressure which is greater than 20, and they had a cardiac index around 2 and a CPO of 0.6. So these patients were all quite sick when they arrived to the hospital. They were able to demonstrate an improvement in 30-day mortality, as seen in the bar graph on the right-hand side. So PA catheter usage was higher in the shock team, so 60% compared to 40. The overall MCS was actually less for shock teams, so 35% compared to 43%. However, the advanced MCS, which is typically defined as Impellas and ECMO, was greater for the shock team, 53 to 43. The overall MCS device is likely less because it appears that they used less balloon pumps. They used more pharmacological therapy, again indicating they took a more tailored approach to each individual patient. And overall, they showed a 6% decrease in CICU mortality. The time to PA catheter placement was also notable for the shock team. It was about, on average, 8 hours versus 16 hours. This is important because if you get a PA catheter in place early and you get your filling pressures and your hemodynamics, you can make a decision about MCS and likely get that in place within the next few hours. So within 24 hours, you can have device in place with a PA catheter assisting in your monitoring. Versus the non-shock team, it took about 16 hours to get a PA catheter in place to assess the filling pressures, and then you're looking at several more hours. So you might not have a device in place for 24 to 36 hours, and we all know that time is important when thinking about shock. They also had less ventilation needs and less renal replacement for the patients who were in the shock team, again, supporting the idea that early MCS helps to preserve end organ perfusion. They did have a decreased ICU length of stay, decreased mortality. The one thing that is notable is that the MCS on transfer was less, or was roughly the same, which is interesting that I believe this sort of signifies that the community is starting to take note of the fact that MCS is important to preserving end organ function. So more patients arrived to the tertiary centers with MCS already in place. So I do think the message is starting to sort of percolate throughout the community that MCS early is important. So going back to our case study, so our patient, a 71-year-old gentleman who presented with chest pain, was found to be hypotensive, tachycardic, initially had sort of preserved end organ perfusion, and was found to have an EF of 25%, and also had multivessel disease and an elevated LV-EDP initially. He was sent to the ICU. There was a conversation between the referring center and our heart failure cardiologist. The recommendations were to start dobutamine and transfer the patient. While waiting on a bed assignment, the patient became more hypotensive, developed a rising lactate, and his mental status started to worsen. He then started having runs of ventricular tachycardia. So he was taken back to the cath lab for insertion of a balloon pump. But unfortunately, he went on to have a cardiac arrest. He underwent ACLS for 20 minutes. Over the next several hours, he had several more arrests, mostly related to unstable VT and worsening cardiogenic shock. By the time transport was available to pick the patient up, there was poor communication with the helicopter transport team, and they did not realize that a balloon pump was in place, so they did not bring a transport console. So a decision was made essentially on the helipad at that time to go ahead and disconnect the balloon pump, place the patient on a continuous CPR device, a Lucas device, and transport the patient to our facility. Upon arrival, he was essentially dead, and he passed away. He passed away shortly thereafter. So, what did we learn from this? Well, we learned that early recognition of shock is key, and reassessment is probably more important. We learned that invasive hemodynamics could facilitate optimal MCS device. So I think if that patient had had a PA catheter placed at the time of his initial cath, and we'd gotten a set of filling pressures and hemodynamics, we probably would have realized how sick that patient was, and he might have gotten a balloon pump or an Impella at that time versus several hours later. We also learned that communication with the tertiary center is of the utmost importance, and if we had known that the patient was deteriorating We probably could have mobilized our ECMO team and gone to their center to cannulate the patient and put him on a more stable support system and transported him safely. And so we are in the process of forming a cardiogenic shock team to streamline the communication, protocolize hemodynamic assessments and MCS device implantation in the hopes that we can avoid more tragic outcomes such as this one. So just a couple questions to sort of highlight the important topics of this talk. So invasive hemodynamic monitoring is a key component of early recognition and management of cardiogenic shock. Correct. Great. And cardiogenic shock teams have demonstrated improved outcomes in the treatment of cardiogenic shock. Correct. That's perfect. Oof. We have a contrarian opinion in the audience. All right. Well, thank you, everyone, for listening, and I'm happy to take any questions.
Any questions for Dr. Tomas?
All right. Thank you, everyone.
Need me to load the slide? Okay. Jeez, where's the friggin' slide? All right, our next speaker is Dr. Purav Shah. He's one of our lung transplant and critical care physicians here at Emory. He'll be talking to us about the bridge to lung transplant with ECMO.
Thank you. Good morning, everyone. My name is Purav Shah, and I'm one of the transplant pulmonologists at Emory University. Before I begin, I want to thank the organizers for giving me an opportunity to talk today. And over the next 15 to 20 minutes, I'll try and talk about how we can use ECMO as a bridge to transplant in our end-stage lung disease patients. I don't have any financial disclosures, and these are the objectives for my talk today. And I do have a couple of questions in there as well. So prior to 2005, lung allocation in the United States was done solely based on how long a patient has been waiting on the wait list. That is, it was a first come, first serve. However, in May of 2005, the lung allocation score system was introduced, which prioritized lungs based on medical urgency, with a goal to reduce waitlist mortality. As a result, transplant centers across the country started listing more sicker patients, and there was an increase in demand for mechanical circulatory devices, namely ECMO. So this slide shows that over the past 3 decades, there has been an exponential increase in the number of patients that have been on the wait list. Unfortunately, the number of transplants and the donor pool are still lagging behind significantly. This slide shows that prior to 2010, less than 1% of the total transplants that, lung transplants that took place in the United States used ECMO as a bridging therapy. However, starting 2013, that number has increased anywhere from 4.5 to 6% of the total transplants that used ECMO as a bridging therapy. This is data. This is the most recent data that was published in March of 2022. It was published by the UNOS and the SRTR, which is the official society that looks at the all organ transplants across the country. And as you can see, there were 2,578 patients that received lungs, but unfortunately, only 37 lungs were transplanted for every 100 donors that were available. As a result, Patients continue to wait and get sicker on the wait list, and some of them, about 149 patients, died past year waiting for an organ to become available. The same paper also looked at the amount or the number of ECMO transplants that were done, and as you can see, in the year 2020, we used about 6.7% of the total transplants that took place in the United States were done using ECMO compared to 4.6% in 2015. So there has definitely been a slow but a definite trend in increase of transplants using ECMO as a bridging therapy. So with that, this is the first question that I have for the group. We have Mr. Smith, who's 42 years old, has ARDS, has been on ECMO for almost 5 months now. He was paralyzed, prone, got high-dose steroids, and then eventually candidate for ECMO. And his current WENT and ECMO settings have been stable for several weeks now. This is his ABG, pH 7.4, CO2 of 38, and O2 of 150. And he still requires significant amount of ECMO support. So what would be the next best step? Well, I guess I'll go with the majority. The correct answer is actually consulting the lung transplant service for an evaluation. This is a good segue into the next topic of my discussion today, and that is the criteria for lung transplant. Unlike the Eurotransplant group, acute respiratory distress syndrome is not an indication for lung transplant in the United States. At least that's what it was before the COVID pandemic. And as a result, there are no definite consensus guidelines on who should be transplanted and when should they be transplanted. However, majority of the centers across the country will use the following criteria when using ECMO as a bridge to transplant. The first one is that the patient needs to be less than 65 years of age, and this is a totally institutional dependent criteria. The second one is they need to have a single organ dysfunction. The third, again, it's more of a gray area, is evidence of irreversible lung injury, and every center has their own way to define what irreversible lung injury means. The fourth one is that the patient needs to be awake and able to participate in rehabilitation. And finally, center experience and comfort with ECLS and lung transplant. Over the next few minutes, I will talk regarding the evidence behind all these criteria. So this was a study done using the UNOS database, and the authors looked at about 561 patients that were bridged to ECMO, bridged to lung transplant using ECMO, and about 91% were less than 65 years old, and about 9% were greater than 65. And as you can see on the Kaplan-Meier curve, the 1 month, 1 year, and 5 year survivals were significantly lower in the older age group compared to the patients that were less than 65 years old. When it comes to organ dysfunction, this was data published by the Hanover Transplant Group that looked at about 200 patients that were bridged to transplant using ECMO. And about 60% of these patients required renal replacement therapy for AKI. And as you can see on the Kaplan-Meier curve, patients that required, patients that required renal replacement therapy had a significantly lower survival compared to those that did not require any renal replacement therapy, with about only 17% of these patients surviving to 90 days compared to 53% in those who did not require renal replacement therapy. Oops. Similarly, this is data published by the Munich Lung Transplant Group, and they looked at SOFA scores and bilirubin as markers of organ dysfunction. And as you can see, those patients that had higher pre-ECMO and pre-transplant SOFA scores had a poor survival compared to those who had lower scores. And similarly for bilirubin levels, the non-survivors had higher bilirubin levels compared to those who survived, with a median of 4.2 milligrams compared to like 1.1 in the survivors. The next criteria is ability to participate in rehabilitation, and this was a really good study done by the Columbia Lung Transplant Group that looked at about 121 patients that were placed on ECMO as a bridge to transplant, and they were successfully able to transplant only 70 of these patients. However, there was no difference between the survival between the ECMO and the non-ECMO group. But when they did their multivariate analysis, they found that ambulation was an independent factor that was associated with improved survival in these patients with an odds ratio of 7.5. The interesting thing is that these patients received anywhere from 4.5 physical therapy sessions per week and ambulated about 55 to 525 feet per session, which is very impressive. Similarly, Hakim and colleagues at Cleveland Clinic looked at length of ICU stay and hospital stay in ECMO patients that were bridged to transplant. And as you can see, the group that was ambulatory had shorter ICU and hospital stay compared to those who are non-ambulatory. And finally, this was another retrospective cohort study using the UNOS database where the authors classified lung transplant centers into 3 categories depending on the number of transplants they did over the past 5 years. And the low volume center was defined as a center that did less than 25 transplants a year. Medium volume was anywhere from 25 to 49 transplants per year, and high volume centers were those that did consistently more than 50 transplants per year. And as you can see, the mortality risk was significantly higher when patients were bridged to transplant using ECMO in the lower volume centers compared to those in the high functioning centers. The same paper also went ahead to say that as a lung transplant program goes and they approach 35 annual lung transplants per year, the hazard ratio of increased mortality from ECMO bridging is abolished and the outcomes become almost similar between those that were transplanted using ECMO bridge versus the standard. These are some of the absolute contraindications to lung transplant patients, and this was published by the ISHLT last year. The first one is lack of willingness to accept a transplant, malignancy, GFR of less than 40, any ACS, MI, or stroke in the past 30 days, patients who have liver cirrhosis unless they're being considered for a multi-organ transplant, patients who have active substance abuse or dependence, patients who have active septic shock, pulmonary or disseminated infection, active TB or HIV with a detectable viral load, a limited functional status, or repeated episodes of non-adherence. So with that, I come to my next question. We have another Mr. Smith who's 46 years old with ARDS and has been on ECMO for almost 18 weeks. He was transferred from an outside hospital for a transplant evaluation, and upon arrival, he was found to be profoundly deconditioned with 1/5 strength in all extremities. He has a stage 4 D-cube ulcer, and he's colonized with multi-drug resistant Stenotrophomonas. So which of the following would be a contraindication to lung transplant? Good. I guess everyone was listening. So profound deconditioning is the correct answer. These are the different cannulation strategies that we use for patients who are being transplanted using ECMO bridge. And depending on whether they have isolated lung failure or they have lung plus RV failure, you can use either a traditional VV or a VA ECMO configuration. You can also use the ECOR, which is a extra membranous CO2 removal devices, and the only FDA-approved device in the United States is the Hemolung. In the European countries, there's a device called the Novalung, which does essentially the same thing. And then, of course, if you have RV failure, you have the percutaneous RVED device known as the Protect Duo. And I'll briefly show you pictures of these devices. So this is the dual lumen cannula. This was developed by Wang and Zwischenberger out of University of Kentucky, was approved by the FDA in 2008, and it is marketed by the Getinge company as the Avalon Elite dual lumen cannula. There's another dual lumen cannula in the market that was it's called Medtronic. It's called Crescent cannula, and it's produced by Medtronic. As you can see, you have a single cannula that has 2 ports. You have a distal port that is the drainage port, and you have a more proximal port that's sitting in the RA and directing the jet towards the tricuspid valve. This is an actual patient with an Avalon or a dual lumen cannula using the subclavian approach, and as you can see, the cannula, and after entering the subclavian artery, the distal port will be sitting in the IVC. This is a dual lumen percutaneous RVAD device, also known as the Protect Duo. It's very similar to the Avalon cannula that I just showed you, except that you have the drainage cannula that's sitting in the RA with a reperfusion cannula that's sitting in the PA, thereby completely bypassing and offloading the RV. This is another actual patient that had a Protect Duo cannula placed using the subclavian approach, and as you can see, the tip of that cannula is sitting in the PA, and thereby completely offloading the RV. This is known as the sport model. It's just a fancier name for upper extremity VA cannulation, where you use an IJ drainage and a subclavian return. It helps with easier ambulation and avoids the north-south or the Harlequin syndrome or differential hypoxia. Unfortunately, it is associated with a higher incidence of bleeding. So the picture on the left shows what an ECMO patient should actually look like. The patient is awake, she's participating in physical therapy, not sedated, not paralyzed. But unfortunately, what we usually end up seeing is patients that are bedbound, paralyzed, on a ventilator, on multiple drips, and not participating in physical therapy. These are some of the outcomes that have been published by some of the large centers. The first one is out of Columbia University, where they looked at 121 patients over a period of 10 years, out of which 59% were successfully bridged to transplant, with an excellent 1 year and 3 year survival of 88 and 83%. And this is at par with patients that do not use ECMO as a bridging therapy. Similarly, Hakim Ali out of Cleveland Clinic looked at 30 patients, out of which 87% were successfully transplanted using ECMO, with 85% 1 year survival and 80% 3 year survival. Our colleagues in Toronto put 71 patients on ECMO as a bridge to transplant, out of which 88% were successfully bridged, with a 70% 1 year and a 63% 3 year survival. And finally, our colleagues in Hanover put 87 patients on ECMO as a bridge to transplant, out of which 78% were successfully bridged, with 79% 1 year survival. And as you can see, most of, or majority of the centers use VA or VV as their configuration, ECMO configuration of choice. And so the UCLA group actually looked whether VV was better than VA versus the no ECMO group. So over a period of 8 years, they had 58 patients that were placed on ECMO as a bridge to transplant, 27 on the VV arm and 31 on the VA. And about 78% or 21 patients were successfully bridged in the VV arm versus 26 or 84% of the patients in the VA group. And as you can see on the Kaplan-Meier curve there, patients who were transplanted using the VV ECMO had an exceptionally high survival of almost 95% survival at 3 years, which is unusually high for anyone, actually. And the authors do say that this significantly better survival was because these patients were young, with a median age of about 44 years, and they cherry-picked or very carefully selected who they wanted to transplant using an ECMO bridge. Some of the challenges that we face when using ECMO as a bridge to transplant, the first is resources. It's a very resource-intensive process. You need a multidisciplinary physician team. You need ancillary staff that is well-versed with ECMO and transplant. You need to have enough ECMO circuits and adequate ICU beds, because these patients can be on ECMO for several weeks to months while they are rehabbing. The second challenge that we face is in the pre-transplant evaluation. As these patients do not have any transplant education, we are unable to get a good psychological assessment in these patients, and a lot of these patients have underlying depression and anxiety that gets missed all the time. Social support also continues to be a big issue for these patients, and the compliance with their post-transplant lifestyle is also a big factor. In terms of institutional challenges, we already talked about transplant center size and experience. The ability of the transplant center to have a good donor pool and the ability to perform desensitization, as some of these patients might be sensitized and not be able to get all the organs that are available in the pool. So in conclusion, ECMO is increasingly being used as a bridge to transplant, and their outcomes have steadily improved over the past decade. When used in carefully selected recipients, the outcomes are similar or sometimes even better. Awake and ambulatory ECMO is associated with better outcomes, whereas multi-organ dysfunction and older age is associated with poor prognosis. Cannulation strategies will depend on the underlying comorbidities, whether they have isolated lung failure versus lung and RV failure, and also depend on the center comfort and experience. It's a highly nuanced, resource-intensive, and center-specific, and successful bridging depends on how comfortable a center is with ECLS and lung transplant. And finally, high-quality trials or research do not exist, and I don't anticipate there's anything that's coming up in the near future. And with that, I'll be happy to take any questions.
So in your first question, you presented a case of someone who was on ECMO for 5 months before you raised the question about ECMO.
Correct.
That seems way too long. Is there a recognition, a guideline, or a thought in terms of if you have a young COVID patient who has to go on ECMO, at what point would you want to give the call or consider this patient for transplant? A week, 2 weeks, a month?
So, like I said, ARDS has never been a criteria for lung transplant, so none of the societies, none of the guidelines do say that, hey, this is when you need to, at least before the pandemic, nobody knew, before the COVID pandemic, nobody knew what is a good time to put these patients on the list or get evaluated. So, no, there are no existing guidelines that would say that, hey, this is the right time. However, from our personal experience, I can tell you that we had about 20 patients that stayed on ECMO for more than 50 days, so more than 7 weeks. And they were all sent to us for a transplant evaluation, out of which only 4 actually needed a transplant. 5 of them unfortunately died, and 11 actually got discharged from the hospital alive. So what we have noticed as time progresses, some of the lung injury does reverse, and we have been able to take patients off ECMO, even though they have been on it for like several months. So that area is still pretty gray, and we don't have a definite cutoff that, hey, 4 months on ECMO and you need a transplant. We have seen patients that have stayed on ECMO for like 3 months, 4 months, and we have been able to take them off.
So we'll take our next break, and then we're going to regroup with our plenary speaker at 11 a.m. Thank you.
Please stop by our posters in the hallway. Thank you.